Okay, let's unpack a particularly crucial and pretty dense chapter. Pediatric immunity and immunologic disorders.
Yeah, definitely dense.
This deep dive is really tailor-made for you, the learner, to try and cut through some of that complexity and pull out the absolute clinical essentials you'll need.
That's exactly right. Understanding pediatric immunity, it isn't just about like memorizing disease names.
Right.
It's really about getting a handle on the core differences between a child's immune system, which is always changing, and an adult's, which is, well, more established.
Okay.
So our mission today really is to clarify those foundational variations, look at the key diagnostic tools, distinguish between the main categories: immunodeficiency, autoimmune, allergic disorders,
Okay.
and always focus on the practical, sometimes life-saving nursing care.
Yeah, there's a lot of ground to cover here. I mean, everything from primary immunodeficiencies like SCID to managing chronic stuff like lupus.
Absolutely.
So where should we start? Maybe right at the beginning.
Yeah.
Like, why are babies, especially newborns, so vulnerable?
That's the perfect starting point. The main reason is just developmental immaturity. Their inflammatory response capacity is decreased.
Okay.
The structures are there, lymph nodes, tonsils, but they're just not very efficient at first.
Right.
But what really drives that susceptibility is the timing of the protection they get. We need to look at humoral versus cellular immunity.
Okay, humoral. That's the antibody protection, right? B cells.
Exactly. B cells secreting antibodies. And the critical piece for newborns is that IgG antibody.
The one that crosses the placenta.
Yes, that's the one. It gives the baby passive immunity, which is great, but it's temporary.
Ah, okay. How temporary?
Well, the half-life of that maternal IgG is only about 25 days.
Oh, wow.
Yeah, so that maternal supply drops off pretty quickly, and this leads directly to a very specific window of vulnerability.
Okay.
We call it physiologic hypogammaglobulinemia.
Hypogammaglobulinemia.
Okay, it typically hits between 2 and 6 months of age.
So what does that mean, clinically speaking, during that window?
It means the infant is at a much higher risk for common bacterial infections.
Right.
Because their own antibody production hasn't fully kicked in yet to protective levels, especially for things like IgG and IgA.
And the other types, IgA, IgM, they don't cross the placenta at all.
Nope. IgA, IgD, IgE, IgM, none of those cross. The baby has to make them after being exposed to antigens.
Okay. And then the other side of the coin, cellular immunity, P cells. That's underdeveloped too.
It is. Cell-mediated immunity controlled by T cells. It's just not fully functional at birth. And crucially, maternal T cells do not cross the placenta.
So the baby's completely reliant on its own T cell response from day one.
Exactly. And that response is, well, sluggish. Newborns have decreased phagocytic activity, decreased chemotaxis, basically a weaker inflammatory reaction.
Which explains why certain tests like the PPD for TB aren't very reliable early on.
Precisely. Those tests depend on a strong cellular reaction, which often doesn't fully develop until about 1 year of age.
It really is all about timing and development, isn't it?
It really is.
Okay, so before we get into specific diseases, let's talk about the nursing process. Assessment. You mentioned red flags earlier. What are those 10 warning signs of primary immunodeficiency nurses need to know?
Right. These are critical for screening. They help us separate, typical childhood bugs from a real systemic immune issue.
Makes sense.
So we look for patterns, like 4 or more new episodes of acute otitis media in 1 year.
4, okay.
Or 2 or more serious infections like sepsis or meningitis in a year.
Wow.
Recurrent deep skin or organ abscesses.
Yeah.
Needing IV antibiotics to clear infections.
That feels like a key one, the IV antibiotics.
It really is. It signals that oral meds aren't cutting it. Also, persistent oral thrush or skin candidiasis after age 1. A family history of primary immunodeficiency, failure to thrive. Those are the big ones.
That threshold seems quite high. 4 ear infections, 2 serious pneumonias. Is that designed to filter out kids who just go to daycare and catch everything?
Absolutely. You hit the nail on the head. We need to distinguish between a kid getting exposed to common viruses and a child whose actual immune system is failing.
Gotcha.
The need for IV antibiotics, those deep abscesses, those suggest a systemic failure, not just exposure.
Okay. Now, diagnostics. What lab work helps differentiate? Like, is it an antibody problem or an autoimmune thing?
Yeah, good question. So The CBC with differential is standard, obviously.
Hmm.
But for deficiencies, we really rely on immunoglobulin electrophoresis.
Okay.
That measures the specific levels IgA, IgE, IgG, IgM. It's essential for diagnosing things like hypogammaglobulinemia.
And I remember reading the normal ranges for some tests change a lot with age, right?
Oh, dramatically. Take the CD4 count, the T helper cell count, crucial for HIV monitoring.
Yeah.
A normal count for a 2-month-old might be over 1,500 cells per cubic millimeter.
Okay.
But for a 6-year-old, anything over 500 is considered normal. The whole system matures and the numbers shift.
That's a huge difference, important to remember. And then for the autoimmune side, where the body's attacking itself.
For those, we often look at ANA, anti-nuclear antibody, and RF, rheumatoid factor. These detect autoantibodies linked to diseases like SLE or juvenile arthritis.
Okay.
And we should also mention allergy skin testing.
Ah, yes. Critical point there about medications.
Absolutely critical. Antihistamines must be stopped beforehand. They'll suppress the reaction, making the test useless.
Right.
And of course, you always have to be ready for potential anaphylaxis during the testing itself. Have epinephrine ready.
Good point. Okay, that leads us nicely into primary immunodeficiencies, the congenital ones. Let's start with hypogammaglobulinemia. You mentioned it earlier.
Right. So this is basically a lack of adequate antibody production. Most types are managed by giving the patient what they're missing.
Which is?
Immunoglobulins, usually through routine IVIG infusions, intravenous immune globulin.
Okay. Any key nursing points for giving IVA?
Yes, a really important practical one. Do not shake the vial.
Don't shake it. Why not?
Shaking actually denatures the protein. It breaks down the immunoglobulin, makes it ineffective.
Oh, okay. Good to know.
You just gently swirl or roll it if needed, and always monitor closely during the infusion for side effects like renal issues or, rarely, anaphylaxis. Pre-medication might be needed.
Got it. Okay, next up. Wiskott-Aldrich Syndrome. X-linked, affects boys.
There's a classic triad, right?
That's the one. The triad is immunodeficiency, severe eczema, and thrombocytopenia, low platelets.
Thrombocytopenia, so bleeding issues.
Often, yes. The first sign might actually be prolonged bleeding, maybe from the umbilical stump or after a circumcision because of those low platelets.
And management.
It involves IVIG, really meticulous skincare for the eczema, sometimes splenectomy, but the only actual cure is a hematopoietic cell transplant.
A bone marrow transplant, basically.
Essentially, yes.
Okay. Now the big one, the emergency. Severe Combined Immune Deficiency, SCID. Total immune system failure.
Pretty much.
Yeah.
Absent T cell and B cell function. These infants are incredibly vulnerable. It's a true medical emergency. And infection prevention is everything.
Absolutely paramount. Which brings us to a critical point about blood products.
Okay.
If a child with SCID needs a transfusion, you must use only CMV negative irradiated blood or platelets.
Irradiated. Why is that step so crucial? What happens if, in an emergency, only regular blood is available? Do you wait?
You absolutely wait. This is non-negotiable.
Oh, wow. Okay.
If you give non-irradiated blood, the viable T cells in the donor blood will recognize the baby's body as foreign and mount a massive attack.
Graft versus host disease.
Exactly. Fatal graft versus host disease, or GVHD. In an SCID patient, it's essentially 100% fatal. So delaying the transfusion until you have the correct irradiated product is literally life-saving, even if the delay feels scary.
That is a critical piece of information. Okay. Let's shift from primary deficiencies to the major secondary one, HIV infection in children. How does it differ from adults?
The key difference, especially with vertical transmission mother to child, is the impact on the brain.
The brain.
Yes. In kids, HIV rapidly invades the central nervous system. This can lead to something called progressive HIV encephalopathy.
Encephalopathy, so neurological damage.
Yes. It causes acquired microcephaly, the head stops growing properly, motor deficits, and really tragically, loss of developmental milestones.
Oh, wow.
And what's really alarming is that these neurological signs can show up before you see significant immune suppression in the blood work.
So nursing care has to address both infection risk and development.
Absolutely. Heavy focus on preventing opportunistic infections, which means being very careful with vaccines, especially live ones. No live vaccines without specialists say so.
Right.
And then strict compliance with antiretroviral therapy, the ART drugs.
Compliance is key anyway, but especially here.
Especially here, because ART isn't just about lowering the viral load. It's crucial for trying to stop that progressive encephalopathy and preserve brain function.
That's huge. Okay, let's change gears again. Autoimmune disorders, body attacking itself. Let's start with the classic, SLE, Systemic Lupus Erythematosus.
Right, SLE. It's a multi-system inflammatory disease. Basically, Immune complexes get deposited in tissues all over the body, causing inflammation, especially in blood vessels vasculitis.
And the telltale sign we learn about.
The classic malar rash or butterfly rash across the cheeks and nose.
Right.
Also, photosensitivity is common, and you have to watch for signs of organ involvement, particularly the kidneys. Keep an eye on blood pressure.
Nursing care must be complex, managing long-term meds.
It really is. There's a lot of education, like teaching families about consistent daily sunscreen, use minimum SPF 15 because sun exposure can trigger flares.
Okay.
And then there are the medication side effects. Long-term high-dose corticosteroids are common.
Yeah, those carry risks.
Big risks. One we really watch for is a vascular necrosis.
Lack of blood supply to the bone.
Exactly. Usually in a joint like the hip. It causes tissue death. So any new unexplained joint pain in a child on long-term steroids needs immediate investigation. It could be AVN.
Definitely something to flag.
Mm-hmm.
Okay, what about Juvenile Idiopathic Arthritis, JIA?
JIA involves autoantibodies attacking the joints. You get inflammation, pain, and stiffness.
And that characteristic morning stiffness.
Yes, exactly. Stiffness is usually worse after periods of inactivity, especially first thing in the morning.
Management involves.
Typically, NSAIDs for inflammation and pain, and then disease-modifying drugs, DMARDs, like methotrexate, to try and slow the disease progression.
Methotrexate. That requires careful monitoring too, right?
Oh, definitely. It's a potent drug. Nurses play a huge role in teaching families about it, stressing the need for regular blood tests to check for liver or kidney toxicity and monitoring for side effects.
And non-drug approaches.
Yeah, managing pain, of course, but also maintaining mobility is key. Physical therapy, occupational therapy. Swimming is often recommended.
Why swimming?
It's great because it allows for range of motion and muscle strengthening without putting stress on the joints. Low impact.
Makes sense. The goal is always quality of life, keeping them in school.
Absolutely. Promoting normalcy as much as possible.
Okay, final section. Let's tackle the acute stuff. Allergies and especially anaphylaxis. Life-threatening potential here.
Yes. Anaphylaxis is an immediate IgE-mediated systemic reaction. It can escalate incredibly quickly.
Key warning signs nurses need to spot instantly.
Look for anything involving the airway first. Lip or tongue swelling, stridor, that high-pitched breathing sound, shortness of breath, wheezing.
Okay, airway first.
Then cardiovascular. A sudden drop in blood pressure, faintness, rapid, weak pulse. Skin signs like hives or flushing can be there too, but the respiratory and cardiovascular signs are the most dangerous.
And treatment is immediate.
Immediate. ABCs, airway, breathing, circulation, and epinephrine right away.
Which brings us to the EpiPen. Critical skill.
Yeah.
Can you walk us through the steps clearly? Imagine you're teaching a parent or a student.
Okay. Absolutely vital skill. First, grab the EpiPen or EpiPen Junior firmly in your fist. Make sure the black tip or orange, depending on brand, is pointing down.
Fist, black tip down. Got it.
Second, pull off the safety release cap, usually gray or blue. Pull straight off, don't twist.
Okay, safety cap off.
Third, swing and jab the black tip firmly into the outer thigh. Straight in, like a 90-degree angle. You can do it right through clothing if necessary.
Outer thigh. Hold it there.
Yes. Hold it firmly against the thigh for about 10 seconds. You might hear or feel a click. Count slowly to 10.
10 seconds. Then what?
Remove the pen and then massage the injection site for another 10 seconds. This helps disperse the epinephrine.
Okay, massage for 10. And the most important step after giving the injection.
Call 911 immediately.
Even if the person seems better.
Absolutely. Anaphylaxis can have a second phase, a biphasic reaction hours later. They need medical evaluation, always. And the used EpiPen goes with them to the hospital.
Crucial. We should also quickly touch on latex allergy. Still relevant, especially in healthcare.
Yes, definitely. It's another IgE-mediated response. Screening is key. Ask patients, especially those with frequent healthcare exposure or other allergies, if they react to things like rubber gloves or balloons.
And those cross-reactive foods.
Right. Ask about reactions after eating banana, kiwi, avocado, or chestnuts. A reaction to those can sometimes signal a potential latex sensitivity. Management is strict avoidance.
Okay, so we've covered a huge amount of SCID, HIV, lupus, JIA, anaphylaxis.
Yeah.
If you had to boil it down, what's the single biggest takeaway for a nurse caring for any child with an altered immune system?
It really comes down to one thing: prevention of infection.
Infection prevention.
Yes. Whether it's primary deficiency, secondary like HIV, or even autoimmune disease where the treatment suppresses immunity infection is the constant threat.
Some meticulous hand hygiene.
Meticulous hand washing, yes. strict adherence to any prescribed prophylactic antibiotics, intense education about medication compliance, whether it's ART for HIV, DRMARDs for JIA, or IVIG.
And remembering the whole child, not just the disease.
Exactly. The psychosocial impact is enormous. These are chronic conditions. They cause immense stress for the child, for the family. Part of our job is providing support, connecting them with sources, helping them achieve as normal a life and developmental path as possible.
We've definitely hit the key physiologic issues, the diagnostics, and the really specialized nursing care needed for these complex pediatric immune conditions.
We have. Now, maybe a final thought for our listeners to chew on.
Okay, let's hear it.
All right. Given the constant need for infection precautions, sometimes even isolation, and the very real risk of developmental delays we see in conditions like HIV encephalopathy, how can a nurse get really creative? How can they tailor safe play and educational activities to truly meet the developmental needs of a child in the hospital whose chronological age might be, say, 5, but developmentally they're functioning more like a 2-year-old? How do we bridge that gap effectively and safely?
That's a fantastic question, something to really think about in practice. Thank you for joining us on this deep dive into pediatric immune and immunologic disorders.
Oh, my pleasure.
We genuinely hope this has helped you get a solid grasp on this critical chapter and given you confidence moving forward.